Well, welcome everyone to the second BC Support Unit webinar entitled Who Me? Yes, You, Becoming a Patient Partner in Health Research. Our presenters today are, Colleen, would you mind going? Thank you. Presenters today are Colleen McGavin, Patient Engagement Lead with the BC Support Unit, Kent Loftsgard, Patient Partner with the BC Support Unit, Annie Moore, who is the Research Education and Grant Facilitator at Island Health Research Department, and Jaime Ascher, Patient Partner and President of Still Life Canada. Today's webinar I'll have you all muted throughout the presentation, and you'll be unmuted at the end for a Q&A session. You can either use your voice for asking a question via either your computer or your telephone, or you can use the chat function. The chat box is located in the bottom right-hand panel right now, and if you click that, you'll see that there's a space into which you could post your question. An evaluation survey will be emailed to you after the webinar using the email address you used to connect to this webinar, and we thank you in advance for taking time to complete it so that we can use your input to improve future offerings of webinars. So with that, I'll ask Colleen if you would like to get underway.
Yes, thanks, Pat, and welcome everyone. I'm Colleen McGavin, the Patient Engagement Lead with the BC Support Unit. We have 4 goals for this presentation today. First of all, we want to introduce patients and the public to the idea of patients as partners in health research. And we want to give some examples of roles for patient partners in health research, which is why we have 2 patient partners co-presenting with us today. We also want to talk a little bit about how the support unit is working to foster patients as partners in health research, and to let you know how you can become engaged too, in case anything we say here today piques your interest or desire in becoming a patient partner. So when I go out and talk to my friends and family and ask them this question, what comes to mind when you think of health research? Often the first thing that comes to mind is a scientist with a white coat in a lab with a microscope or a petri dish. And, you know, we might refer to this as research for patients. Other people can recall times when they themselves, or maybe a member of their family or a loved one, was what we would call a participant or a study subject. And we might call this research on patients. So a study looking for a new drug or a therapy to cure or help someone with a disease or a condition. Other people, and particularly I would say anyone who's been involved with an organization like Patient Voices Network or so on, probably has some experience being part of a focus group or perhaps filling out a survey to find out what their opinions are, what their experience has been. And we might call this research about patients. Now, when it comes to patient-oriented research, which I'll be talking about quite a bit, we're not exactly talking about any one of these. So, but then what is patient-oriented research? So patient-oriented research has 4 dimensions to it. One, firstly, it engages patients as partners on research teams. And as that name would imply, our goal is to have patients be collaborators along with researchers in the design and conduct of research. The second facet of patient-oriented research is that it focuses on patient-identified priorities. So it's about asking patients, where are the gaps that you've experienced in your care, and what research do we need in order to fill those gaps? It is research that is intended to improve patients' lives in ways that matter to patients, and that it isn't always the same. Like, researchers aren't necessarily totally tuned in to the things that matter most to patients, and we'll talk about that a little bit later in the presentation. And fourthly, it's very much about applied research. That is, research that aims to apply the knowledge generated by research to improve healthcare systems and practices. There is a definition from an organization in the UK called Involve, which has a long history of engaging patients and the public in health research, and I really like it. They simply describe patient-oriented research as research with and by, not to, for, or about patients and the public. You might be asking yourself, why do we want to do patient-oriented research? Why has this become such a big thing now? Well, actually, the idea has been around for quite a while, and it really started with a moral argument that said that people have a right to be involved in publicly funded endeavors that affect them personally. It's actually really a gut sense that if you got people involved, patients and the public involved, we would see major benefits. The second argument is around the need for greater impact on policy and practice change. So there has been some study done around what kind of impact research, health research has, and some of the statistics coming out of those studies are rather alarming. For example, one study, or I think it was a review actually of studies, showed that it takes on average 17 years for the results of a study to make it into policy and practice. And actually only about 14% of research does have a longer-term impact on policy and practice change. So we want to improve those numbers. Another argument is around relevance. So it says that patients know what matters to them and which treatments and therapies are most likely to be acceptable by them. So we should involve them. And then finally, there's the quality argument, which says that patients bring a unique perspective that complements scientific and academic expertise. So it doesn't replace all of that knowledge and expertise that a scientist has by virtue of going to university for all those years and studying and training to be a researcher. But the scientist may not have that lived personal experience of what it's like to live with a particular disease or condition. So obviously, patient engagement is a huge part of patient-oriented research. So I'd like to go through what the definition is under the program that the BC Support Unit comes under, the Strategy for Patient-Oriented Research, or SPOR. This is the definition: meaningful and active collaboration in governance, priority setting, conducting research, and/or knowledge translation. And for those of you who haven't worked in research, I'd like to break that down so that it's a little bit more understandable. So the first part of the definition talks about meaningful and active. And what does that mean? In the words of one patient partner, it's the feeling that you're having an impact, that your voice and perspective matter and can influence decisions. And here we're talking about decisions related to the research itself. What are the important questions to ask? What are the important outcomes to measure? The Strategy for Patient-Oriented Research has developed a patient engagement framework, and in that framework there are certain guiding principles of inclusiveness, support, mutual respect, and co-build. And you can look this framework up if you just Google that phrase, SPOR, Patient Engagement Framework. The second part talks about it being collaboration. Now, many of you will be familiar with this idea of there being a spectrum of engagement. As you move from left to right on this spectrum, an individual's voice has an increasing impact on the decisions being made. And you can see that collaboration, or collaborate, is quite far to the right on this spectrum, and it's defined as partnering in each aspect of decision making. And I would say that today, where we are historically in health research, this is aspirational. This is where we want to get to, but it is part of a large culture change. Then it talks about the specific areas where patients can be meaningfully and active collaborators. The first is in governance. So this is just meant to depict a typical governance structure, and a typical governance structure tends to be rather hierarchical, where you have a highest decision-making group, whether that's a board or a steering committee. It might even be one or two individuals. But feeding into the decisions of that group are often working groups, councils, ad hoc advisories, and so on. And our working definition is that governance includes all those voices that contribute to decision-making about policies, funding, and operations. There was an interesting article published recently that looked at what patients themselves said were their impactful roles within governance. And they described three. They described how they could be the creative outsider and the free challenger, free from institutional perspectives, free to speak their mind without worry about offending peers or affecting their job promotion and so on. And that even just the role of passive presence is an important one, because just by virtue of having a patient at the table keeps people very patient-centered in discussions. At this point, I'd like to introduce Kent Loftsgard, who's sitting right next to me here, who is a patient partner with the BC Support Unit. And Kent is going to talk about some of the roles that he's had within the support unit since you came on board last summer.
Last summer, yes, indeed.
Okay. Over to you, Kent.
Thank you so much, Colleen, and thank you to those of us who have joined us live today, and thank you especially to those of us who will tune in later to hear our archived wisdom for your benefit, such as it is. My role here today is just to give you a little bit of a sense of my background beyond the little blurb that is the bio on the webpage, and also to give you a sense of my patient journey as an engaged participant in the development of the support unit so far. So I come from a professional background in journalism and media communications production, both in broadcast and in print, including a fair amount of event development and live instruction on various health-related topics, etc. And I was recruited out of that in the fall of 2011 to join the health education team at UBC, where we have been developing various interprofessional and interdisciplinary health education programming for the last several years, and that was another ground floor initiative that I'm thankful to be able to get in on the early development and shape of it. And that work led me into being recruited just last year into the Patient Voices Network, right at the time that it was coming under the auspices of the BC Patient Safety and Quality Council, and involvement with the support unit in its very early days was one of the very first engagements that I was asked to participate in on the topic, as you can see there, patient compensation. This is an area that strikes very close to my heart, because I think that it is important to emphasize that patients can be and are relevant professionals as well. And I think that sometimes when we have looked at the area of patient participation in various ways, there seems to be a bit of a misnomer that that you can either be a patient or you can be a professional. But I like the idea that it is possible to be both. And so fair patient compensation is an area that we're still working on. And that led to the formation of the patient engagement working group that was one of two all-day meetings that we have here, basically just to talk about what we want the support unit to do and to be, and sort of shaping the ideals and the direction of what the support unit would become. And then we decided that it would be a really good idea to get all of our team members together in a face-to-face way so that they could have a chance, which I think even for all of the staff members was maybe one of the early chances that they had to meet with each other face-to-face and get an opportunity to build an in-person rapport with each other and to gain an understanding of what each other was going to do as far as their roles within the support unit. One of the things that I emphasize in my healthcare education, working with students in different disciplines, is how can we best identify our opportunities to cooperate and collaborate if we don't really understand what each other does. And then where we are now is that the patient engagement working group has sort of evolved into a more formal type of patient council. And we are looking at things like the terms of reference that will be a guide for us to check back with in terms of measuring our progress and guiding us along the way to becoming what we want to be in the best possible way that we can. In November, I was blessed to be able to be a patient ambassador at the official launch of the support unit that was participated in by our provincial and federal health ministers, as well as by the head of the medical school at UBC, and our methods cluster leader for knowledge translation, Dr. Linda Lee. Then I've been also involved in some screening to select a patient member to represent our interests to the Academic Health Sciences Network board.
I should mention the Academic Health Sciences Network is the parent organization that the BC Support Unit comes under.
And then I've been involved in selecting the leadership of other areas of our methods clusters. We have 4 areas where we have methods clusters formed. Let me see if I can remember them all. Knowledge translation, like I mentioned. Data sciences, I know, is one. Patient engagement is one, and I'm missing one.
Tell me what a methods cluster is.
The methods cluster, and this is something that is relatively new to me, but the methods cluster is basically, it's the way that I understand it is kind of like a guiding think tank for our activities in that area. And our methods cluster leaders will then be responsible for helping to recruit other participants in the methods clusters as we develop those areas of involvement in the support unit.
That's your that's the last point.
That is the last point that is on the slide, but as of yesterday, I was also involved in some screening interviews to select an office assistant here that will be contributing to our home team here in the office of the support unit. So it's a day by day and week by week adventure and new possibilities.
You can see the demand we have for patient partnership in the evolution of the support unit itself, and I would mention that we are going to soon be seeking to expand our patient council. We currently have 5 active members, but we're going to be seeking to expand that to at least 15 members from around the province because we have so much demand within the support unit itself, the operations and governance of the support unit itself. I'm going to have to move on. Thank you very much, Ken. I hope that gave people some ideas, some very concrete ideas of how patients can be involved in governance. And I'm going to move on to talk about patient engagement and priority setting. So priority setting is the process, obviously, of determining what kind of research you're going to do, what are the important questions to investigate. And traditionally, priority setting has been done by academic researchers. They have come up with the ideas for the research, and through the process of peer review or review by their peers, who are also academic researchers typically, they get to do their research. But more recently, arguments have been made that what we call knowledge users, and these would be health system decision makers, healthcare providers like your doctors or your physio, and patients and the public themselves should have more say in what are the priorities that priority topics and questions for research. I'll just give you one case in point. This is one that I use quite frequently from a study that was done in the early 2000s and reported in the Lancet in 2009. And I just put it out there as to illustrate the point. When they looked at where the money was being spent in regards to osteoarthritis of the knee, they found that about 80% of the dollars were being spent on drug evaluations, but only 9% of patients said they wanted more money spent on drug evaluations. Patients were more interested in learning more about physiotherapy, surgery, and educational and coping strategies. So that just shows you how there's perhaps been a disconnect between the priorities of the patients themselves and the research community. So to talk a little bit more about priority setting and how it can be done, I'm now going to turn the presentation over to Annie from the Island Health Research Department. So Annie, I'll advance to your first slide.
Thanks, Colleen.
And turn it over to you.
Thanks for inviting me to speak today. We actually were fortunate enough to work with Colleen in developing this workshop along with 2 other patient partners. And we developed and hosted this priority setting workshop by inviting about 25 patients and informal caregivers to come together and learn about the research process, and then to identify any gaps in care or treatment uncertainties that they had experienced. In other words, to identify unanswered questions they had about their care or treatment. And we included people with lived experience in areas where Island Health Research has strengths, and those included stroke, diabetes, multiple sclerosis, Parkinson's disease, dementia, and schizophrenia and early psychosis. So we brought everyone together in one room for an afternoon and worked through a priority setting exercise where everyone brainstormed their own gaps and questions about treatment, and then each group voted for their top unanswered question. Our department then collected the top question from each group and evaluated those 5 questions to see whether they had the potential for further research. Next slide, please. How do you know if a question has the potential for further research? In order to be a strong and valid research question, it needs to meet 5 criteria that are summarized in a nice acronym, FINER. The F in FINER stands for feasible, meaning you need the right people and resources to conduct the research. Interesting. Traditionally, this would mean interesting to the academic researcher, but as Colleen points out, we are now interested in questions that are interesting to patients and other knowledge users. Novel, meaning the question hasn't yet been answered by other research. Ethical, meaning it's a question we can answer safely and confidentially for the people involved in the research, and that the benefits of conducting the research outweigh the potential risks. And last, relevant. And again, traditionally this would be relevant to the research literature and filling a gap. But in this case, it also has to be relevant to patient outcomes, quality of life, and care. We found that 4 of the 5 questions had been answered by previous research, and we summarized that research and shared it with the participants in a follow-up report. And I just want to note that just because a question doesn't meet the FINER criteria doesn't mean it's not a valid question. It just means it's not a research question. So several of the questions that our patients identified could have become other kinds of projects to improve the quality of care, to provide education to patients and families, to improve communication between patients and clinicians. So even though a question has been answered in the research, the gap or the problem may not yet have been solved locally, and that's where, as Colleen mentioned, knowledge translation comes in. It takes research answers and applies them in practice to change care and treatment. One of the questions that came out of the workshop did meet the FINER criteria and has the potential for further research. Next. And here is that question. if hallucinations are based on the personal landscape of an individual with schizophrenia or early psychosis, why are they not explored like other symptoms of disease? And you can tell it's a good question because it leads to more questions. Initially, actually, we thought that 2 of our top 5 questions met the finer criteria, and the second question was around whether there should be a clinical trial comparing the effects of medical marijuana to other drugs used to treat spasticity in multiple sclerosis. As it happens, that question has just been answered in the literature by a comprehensive review that was published last month in January of this year, which goes to show how dynamic the research process is, but also highlights the value and the importance of engaging patients in the research process from the first when you're setting priorities. The question they developed was timely, it was relevant, it was novel, and it was even prescient, because they predicted a question that was later answered by the research. So in this case, you can see that patient experience and priorities perfectly complemented the existing gap in the literature and the academic research question. Next. So what's happening now with our one question that meets the finer criteria? In order to answer the question about hallucinations, we've put our money where our patients' priorities were and launched a grant competition for $15,000. It's currently open, and we're seeking researchers who will work with our patients to refine and review the question and to work together to answer that question through further research. This grant competition is one way we're trying to make the project feasible by providing resources and trying to identify the right people to conduct the research. We're also going to involve patients as members of the grant review panel, so they'll share in the decision-making about which team should get the funding. And ideally, they'll become part of that team as the research gets started and going forward. Again, ensuring we have the right people involved and that the project will remain relevant and interesting for those people. Next. And I just wanted to conclude with some patient voices. These are from the evaluation feedback we received from our workshop participants about their experience and what it meant to them to be part of the priority setting workshop. And I think these really speak to the power and potential of patient-oriented research. So they said, knowing that patients' voices are being considered a vital part of the process and that better treatment and quality of life will result. They felt a strong desire to see inclusion in the research process and that it was great to engage patients in what mattered to them, that it was important to them to be part of a bottom-up process. And last but certainly not least, they felt hope from being part of this process. And in fact, hope was what we heard the most, that participating had given them hope for the future and for improving care and treatment for themselves and for others.
Thanks, Annie. To me, every time I hear that story, I feel warm inside. That's a really inspiring story. Thank you for sharing it. All right, back to our definition about what is patient engagement, meaningful and active collaboration in governance and priority setting, but also in the actual conducting of the research and the knowledge translation. So here's a diagram of the steps in a research life cycle, and it starts, as we've talked about, with identifying and prioritizing research questions and projects. And it moves through a fairly standard set of steps through the design phase, the development of the grant proposal, preparation for the execution of the study, collecting the data, analyzing and interpreting it, and then once the knowledge has been attained, disseminating that out to the knowledge users so that it can be implemented. And of course, as part of any project, there should be monitoring and evaluation. There's a researcher out of the University of Saskatchewan named Isabella Zeleste, and she put together a document called Roles for Patients, and she has literally itemized dozens of roles that patients can play at these various steps along the research life cycle. And I'm just going to mention a few because we don't have time to go into all of them, but certainly if there is anyone interested in getting more detail on this, we can provide this full document to anyone who's interested. So in the design phase of the project, patients can co-develop the patient recruitment strategy. They know what obstacles and barriers there may be to people with their condition participating in a study. They can review and comment on proposed questionnaires, making sure that the language and so on is appropriate. In the development of the grant proposal, patients can define what matters to them. What are the important outcomes for patients? And as I said, these are not always the same thing as what researchers may define. In the preparation for the execution of the study, patients can, again, assist with writing patient information and consent forms so that they're understandable and ethical. And during the data collection phase, patients can even be the ones to collect the data, to do the peer interviews, to run the focus groups, and so on. And I'm going to stop there because, as I say, there's more detail than I have time to go into. But to talk more about what this looks like in real life, I'm going to now turn the presentation over to Jaime Ascher, who is president of Still Life Canada. And Jaime, just let me know when you want me to advance the slides.
Okay, thanks, Colleen. I'm happy to be here today to talk about my experience as a patient partner in research. I'm a mom of 3 children. I have a daughter, Marissa, who's at school today, and my 2 sons, James and Zachary, who are both stillborn, 3 years apart. When I became involved with the research work Still Life Canada had started, I was unsure of what I could offer, as I was just a bereaved mom. I soon learned that my lived experience was an important asset I could bring to the research process, and that being a bereaved mom was a valuable perspective in disseminating our findings and making change. Next slide, please. I'll give a little bit of background to who we are and how our research came to be. Still Life Canada, Stillbirth, and Neonatal Death Education, Research, and Support Society was founded in 2012 by a group of families who had all experienced the stillbirth of their baby. They all recognized that although their babies were all born at different hospitals, there were similarities in the absence of bereavement care and support after the death of their babies. Stillbirth is hidden, stigmatized, and misunderstood. The grief for this type of child loss is not accepted. In Canada, bereavement research, education, support, and advocacy have not focused on stillbirth specifically. With meeting each other and telling their stories, our founders began to feel a sense of community. It was through sharing and feeling understood and of not being alone that helped after their babies died. These bereaved parents joined together, formed our nonprofit organization, and decided to translate that feeling of a shared experience into action. 1 year after forming Still Life Canada hosted a conference for bereaved parents and selected healthcare professionals. Leading up to the conference, it was decided that it was an opportunity for research into the care and support after stillbirth and neonatal death, research that had not been conducted in Canada. A good place to start would be to collect people's stories so that they could be used to make change in hospitals and in the community. Still Life Canada, with members of their extended family and a core group of volunteers, sought and secured sponsorship and funding. Our funding came from a CIHR grant and through fundraising. Next slide, please. As part of the conference, attendees had an opportunity to attend focus groups where 2 questions were asked and groups of bereaved parents discussed and answered the questions. These focus groups each had a facilitator who was also a bereaved parent or family member and a note taker, and the focus groups were recorded. Next slide, please. What began as an idea to bring together bereaved parents to share their stories led us on a path towards a community-based participatory research project. Our research design was qualitative and exploratory in nature, which aims for an in-depth understanding of participants' experiences and seeks to describe an underexplored phenomenon in order to identify and prioritize research areas. In community-based participatory research, the community participates fully in every stage of the research process. The community is the starting point and the focal point of the research. In our case, the community is the community of bereaved parents and their family members. We also have partnerships in the academic community and the community of healthcare providers. Our research team consists of members of Still Life Canada, who are all bereaved parents or bereaved family members, and also recognized experts in the field of maternity and bereavement care. But it is the core group of Still Life Canada members who carried out each of the research stages. So from conceptualizing and operationalizing the 2013 conference, to identifying the need to formalize data collection in focus groups, to setting the questions and collecting the data, and then analyzing the data that we collected, and then disseminating our findings. At each step in the research process, efforts have been made to increase the capacity of community partners through training. This is where the support and expertise of our academic partners come into play. We've been supported by Fraser Health, the UBC Clinician Scholar Program, and a network of researchers in the field of maternity and bereavement care. We have also been lucky to have a number of bereaved parents and family members with extensive research backgrounds, which has allowed us to really be as community-directed as possible. Next slide, please. An important piece to point out is that because this is a community-based participatory project, as data was analyzed, we met with a wider community of bereaved parents to check in, to continue to ensure that the themes and concepts that were identified resonated with them and speak to their experiences. One of our first knowledge translation activities was an art workshop Still Life Canada hosted. We invited the 2013 conference attendees to the workshop to check in and help solidify the themes and concepts we had identified. It was an afternoon of silent reflection whereby a facilitator guided activities that culminated in an art creation experience for each attendee to create a piece of artwork based on the identified themes that resonated with them in that moment. Since then, we've participated in many knowledge translation activities. We've presented our research at local and international conferences and conducted presentations at local hospitals during rounds and other workshops. After presenting our research at the Stillbirth Summit in Minnesota in June 2014, we became connected with an international organization called the International Stillbirth Alliance. They approached Still Life Canada to host their annual conference in October 2015 here in Vancouver. We spent a year planning and executing the ISA's International Conference on Stillbirth Prevention and Care. Subsequently, our Director of Research, Dr. Lynn Ferralis, has joined their Board of Directors. Still Life Canada is listed as contributors to the Lancet Stillbirth series released in January 2016, and Dr. Ferralis as a co-author on one of the Lancet papers. Our own manuscript, our own research manuscript, is soon to be submitted to an academic journal within the next few months. As a patient partner, I've been involved in writing the manuscript and will be listed as one of the authors. Next slide, please. In summary, Still Life Canada has conducted community-based research as patient partners. An important note is that when we are participating in knowledge translation activities and disseminating our research, that we are talking on behalf of our community, not our own individual patient experience, but rather the collective patient experience that we have studied. This is why the community check-ins are so important. Our research has identified gaps in care and support for the birth of a baby who is stillborn or dies shortly after birth. It aims to improve the supports for other families. Because of the community-based participatory research we conducted, we have been able to share with frontline healthcare providers and also policymakers who are interested in collaborating with us. This research has opened many further avenues in which we can try to create change. As part of the research and an action item from the 2015 conference we hosted, bereaved parents identified that supports were needed and that they would like to have opportunities to interact with other bereaved parents regularly. This led Still Life Canada to create our monthly meetups, which began in March 2016. Another action item from the 2015 conference was to examine the care that women and families who are pregnant after stillbirth receive during their pregnancy. This has led us to our new research collaboration, whereby bereaved parents of Still Life Canada will be working collaboratively with a family physician, midwives, obstetricians as patient partners on a 3-year project focusing on group medical visits for women and families who are pregnant after stillbirth. In closing, this has all originated from bereaved parents as patient partners and the impact that patient partners can have on research. Colleen, I'll pass it back to you.
Thanks, Jaime. Again, another really beautiful and inspiring story And I think one that so well illustrates what the whole part of patient-oriented research is, research that is intended to have an impact on practice and care for real people, real citizens, real patients. So thank you very much for sharing that with us. So I just would like to say a few words about how we're working to support patient engagement here at the BC Support Unit. And if you look down in the bottom left of your screen, you'll see our little logo, the BC Support Unit, Advancing Patient-Oriented Research. That's what we're trying to do. We're not a grant funding body, but rather we work to help with in these three main areas. The first is around recruiting. And not just the patient partners, but it's a lot about awareness raising out in the community of researchers, finding people who, building that awareness and that desire to work in partnership on patient-oriented research. And we can help researchers to connect with patient partners, and I'll speak about that more in a minute. The second area or focus of our work is on training. You heard Jaime talking about how the patient partners did need support and training, and how that was provided through some of the partnerships that you had, Jaime, in your project. And so we have a training and capacity development lead who happens to be Pat Atherton, who is moderating this webinar today. And we're working collaboratively to develop ways of preparing team members. So that's everybody. That's the patients, the researchers, and anyone else interested in working in partnership to be successful. And then finally, we're working to support all of these partners and addressing the question of what kinds of ongoing mentorship and support are needed and how do you provide them. And towards that end, we now have patient engagement coordinators in each of the regions in the province. So the regions correspond roughly to the health authorities, and then each health authority is connected in a dyad with the research, the major academic research university in their area. Now, if you are interested in learning more or perhaps asking some questions, I would encourage you to go to our website, bcsupportunit.ca. There are two buttons there, one that you can use to inquire about services, and you can actually, if you click on that, you can enter your name and your contact information if you would like to speak with someone at the support unit more directly about how we can help with those three things, recruiting, training, and supporting, as well as other things like knowledge translation. You can also click the button to join our mailing list and get updates on what's happening at the support unit. Another thing that you might consider doing is signing up to be a patient partner with Patient Voices Network. So we have a very important relationship with this organization, and we do recruit patient partners through PVN. And as I've tried to show here through this screen capture, the green button there says sign up as a patient partner. What this would enable you to do is to be sent and be kept in constantly informed about opportunities to become involved, including opportunities related to research, because we post through Patient Voices Network. And if you're interested in seeing some of them that are currently open, you might go to the button there, Patient Partners, and check out the engagement opportunities. Another organization that you might think about signing up with if you are in the Vancouver Coastal Health region is KEEN, the Community Engagement Advisory Network. It's a somewhat smaller network, as you might expect, because it just covers the Vancouver area. But I think they have a membership of about 250, and we can also work with them to recruit patient partners. So you might consider, if you're from that area, signing up with them. And now I'd like to turn it back over to Pat, who's going to moderate any questions for myself or any of the other presenters today.
Great. Thanks so much, Colleen, Kent, Annie, and Jaime, for your contributions to today's webinar. I hope that those who were able to tune in real time found it educational. As mentioned at the top of this call, I'll just remind you before you might think you need to leave to get to your next engagement this afternoon that there will be an evaluation coming to you via the email address that you provided when you signed into this webinar. We appreciate you taking a moment or two to complete that evaluation to help guide our future webinar development and delivery. So at this time, I'd like to open the floor up to any questions you might have for Colleen, Kent, Annie, and Jaime. You can either pose your question using your voice or using your keyboard by going to the chat function down in the bottom right-hand area of your screen. You'll see a little icon labeled chat. If you click that, it will pop open chat area. There's a box at the bottom where you can enter your question. And while we're waiting for people to navigate to that, I'll just let you know, Colleen, that we've had a first question asking if you could give the reference for the article on patient governance, and that was back in an earlier slide, 5 or 6, somewhere in that area.
I certainly can. As soon as I look it up in my notes here, which might take a second. So if you want to go to the next question, I'll see if I can find it.
Sure. We have no other questions at this point. Does anybody have any questions for Colleen? I hear mad typing, but I see no questions.
Do you hear me?
Yes, go ahead. Please.
Oh, okay. I'll just say it then. I would also be interested in the document on the research cycles.
Oh, the roles for patients.
Roles for patients, yeah.
Yes.
And I don't know if the slides would be available as well.
Slides will be going up on our website. If you are currently subscribed to the BC Support Unit newsletter, you'll be getting a link through the newsletter showing you where the recording is stored on our website, and the slides will be available there.
Okay, great.
Yeah.
And I had a question for Kent. I was wondering, well, just if you could kind of develop a little bit on how the methods clusters work.
The methods clusters are an area that's relatively new to me as well. But as I said, my understanding of the methods clusters is that they will basically be a guiding body that will help to design and direct our activities in each of the identified methods cluster areas.
The method clusters are intended to be a community of practice in a particular methodological area. Ken read out 3 of them: knowledge translation, data sciences, patient engagement, and I'm starting to remember the 4th one.
There's a 4th one that has escaped us for the moment.
Every methods cluster is led by an academic researcher, and there was a process to identify who would lead the methods cluster. So, for example, the lead for the knowledge translation is called Knowledge Translation and Implementation Sciences Methods Cluster is Dr. Linda Lee. And so it's really focused on the science of a particular methods in a particular area, the science of knowledge translation and implementation methodology, the science of patient engagement, so studying those particular areas. I did find in response to the question about the reference, I did find the reference. The article is entitled, "Is It Worth It? Patient and Public Views on the Impact of Their Involvement in Health Research and Its Assessment," by Joanna C. Crocker et al., and it was published in May of 2016. So if you Google that, you'll actually be able to find that on a website. If you even just Google, "Is It Worth It?" Joanna Crocker, C-R-O-C-K-E-R. And for the person who asked about the document Roles for Patients, that is actually available on our website. If you go to bcsupportunit.ca and look under Resources, there is an Excel spreadsheet with a number of resources, and you will find it there.
Thanks. Thanks a lot.
You're welcome.
Thanks, Colleen. I've just added both of those things to the chat function. If anybody's looking for them, they can find them there. I've also found on our website the methods clusters, and all 8 are listed here, and I will blast through them at high speed. The first one is real-world clinical trials. The second one is mixed methods research, outcomes and experience measurement, health economics, evidence reviews, knowledge translation, and data. And patient engagement also. There's a list of them on the website under About Us.
There we go.
Any other questions for our presenters today?
Patients are members of these of the method clusters. You have patients on the
yes, the plan, as I understand it, is to have patients participating on the methods cluster teams. As I understand it right now, there are only 3 areas that are, of those 8 that were listed, that we actually have leadership in place. My intention at the next available opportunity is to ask Sterling, who is
Sterling Ryan, who's our scientific director.
There we go. That's the title I was looking for. What exactly is the status of seeking the leadership for the other methods clusters? But the 3 that we have leadership selected for, at least in terms of of the beginnings of a screening process, that's part of the screening process that I've been involved in.
To that question a little bit more generally, are there going to be patients on the methods cluster team? One of the things that happened when we brought together a number of patients in the fall to look at how patients could be engaged in work of the support unit overall was basically we came to the conclusion that patients can and should be involved in every area of the support unit. The challenge for us is having enough patient partners, so that's one of the reasons why we are expanding our patient council to at least 15, and we're sort of speculating that that may be a good number, but we're thinking it may need to be larger. We are writing a terms of reference that specifically says that this is a group of people that various areas of the support unit can call upon. So to partner with the leads of the cluster to get that patient perspective. Another issue around that is how do you properly orient people, right, to participate meaningfully and actively in a role such as a patient partner in a methods cluster community of practice. So if it happens to be something like real-world clinical trials, you couldn't just take someone from the public who doesn't know what a clinical trial is, never mind a real-world clinical trial, and put them into a group like that without preparing them adequately. And we've discovered that there's quite a bit of work that you need to do to prepare people to meaningfully and actively participate. So as I said, that's a major area of focus for the support unit, is identifying places where patients can be meaningfully involved, but also looking at how do we properly prepare, train, and support people to have to be successful and to have a positive experience in that.
Not only that, but how do even before that, how do we even identify patients that have qualifications that might be relevant to particular areas of specialty? Which I think that even before we can get to our particular internal training, that's a challenge at identifying the best candidates. But it again strikes on the issue that patients are professionals in many cases as well, and it's important to think about properly qualified patients, not just having patients for patients' sake.
Thanks, Kent. We have another comment. The idea of having approximately 15 patient voices is to have a reasonably large pool to draw from, not to all gather simultaneously, right?
Well, the plan is actually that this group would meet on a regular basis, approximately monthly, and that non-urgent or not sort of more general, perhaps. I mean, we're still learning around this, but we're imagining that this group would meet approximately monthly, but that as people become more knowledgeable about research, what the strategy for patient-oriented research is, what the support unit is all about. Just speaking to what Kent was just saying about qualifications, they become more qualified, if you will, to be able to step in, for example, when there's an opportunity to be part of a selection panel for methods clusters. It's easier to understand what a methods cluster is when you already have some knowledge about what health research is and what methods are. And so we want to build this knowledge base within this council. And then when an opportunity that's maybe we need someone to be part of a working group for a couple of months, or we need somebody to be involved in this project of shorter duration, we would have a group of well-versed, shall we say, people who would feel comfortable putting themselves forward to say, yes, I believe I could be meaningfully and actively involved in that particular project. So it will both be a body that we can go to and ask general questions or more long-term questions, but it will also be a group that we can draw on for some of these more short-term or ad hoc opportunities.
I would say that one of the most important principal goals in terms of expanding the patient council is to bring the broadest possible realistic diversity to the voices and perspectives that we're able to hear from and to draw on, both in terms of qualifications by past experience and in terms of patient or caregiver or family member experience as well. So demographic diversity is a very important aspect of our goal for the composition of the patient council.
Great. Thanks, Colleen and Kent. You're being thanked for the added clarity. Any other comments or questions for our 4 presenters today? By voice or by keyboard through the text, the chat function? Hearing none, then we have 1 minute remaining. I'd just like to thank all 4 of our, oh, wait, we have one more question. Don't hang up yet. If patients would like to study a topic, will there be avenues for this?
I would need clarity on what a topic means. And perhaps that individual who's asking that question, if it's really specific to a project, or do you have time to elaborate now on what you mean by a topic?
Maybe one of the topics of the methods clusters. Yes, no, maybe so?
No.
Okay.
So if participants are more curious or have curiosity that they have, would like to check in with Colleen to get more information, Colleen's contact information is on our website on our contact page, and we welcome you to connect with her to ask these kinds of questions. Thank you very much, Colleen, Kent, Annie, and Jaime, for contributing to this very worthwhile webinar. I'm sure that everyone participating today and tuning into the recording later will find it valuable and educational. So thank you so much, and I wish everyone a grand day. Thank you.
Thank you, everyone.
Bye.
Bye-bye.